Great. It is time
Okay.
for our wonderful state panel. We're going to learn from the learnings of the states as they implemented and improved their individual projects. We're going to have some highlights under each of the individual objectives and really have an opportunity to delve into that from their perspective. You've been hearing from sort of the network and leadership level up until this point, and now it's time to really get into where the rubber meets the road and where the work actually happened, which is on the state team level. So, Bethlen, the floor is yours. Thanks so much.
Great. Thank you. It is wonderful to be able to be here. I think we're giddy. There's a giddiness for those that are here. And also I am giddy to see all of the people that have been able to, there's such a strong presence of, we've had 70 people online. It was so many. It's so wonderful to see so many people that have been able to engage. And it's just an honor to be able to help make that happen and be a part of this. We right now, I'm going to be introducing this, but I want to get up here so that we can keep moving forward quickly and hear, like, get really focused on talking to the state teams. We need to bring up Sarah, our first panel. So we need to bring up, while I'm talking, they can be coming up and joining us up here. So Sarah Perkins from Team Massachusetts, Sandra Gilbert from Team Kentucky, Christy Linson from Team Indiana, Rahel Berhani from Team Texas, and Jill McCormick from Team Washington. And you can see that you have name cards here at the panel table for your convenience. And I thought I was going to have a chair here, but it seems to have gone to that end. Okay, great. So while they make their way up, I do want to introduce to you what we're doing here today. We've had a chance to hear this morning from multiple key thought partners, and that's been such an absolute, you hear from everyone a sense of urgency and where we're at and where we need to be going, and what this has allowed us to kind of catalyze to moving forward and consider that together. And that's what we all have the opportunity to do today, both here in the room and through these virtual opportunities. Hello. So we're going to have a chance now to talk with the teams. As Dr. Warren mentioned, like, they've actually had the opportunity to get in there and really try to see what works, what doesn't work. And they have a deep and practical understanding of this on the ground to try to look at how we advance systems of care. So we all, as Dr. Warren also said, have a pivotal role to play. And I think we realize the only way that we're going to get there is to have all these perspectives represented that can help come together and see how we get this done, practically speaking. And the state teams saw that chance and they embraced their roles with fervor through a pandemic, no less. And along the way, something shifted for many people. And we've heard this again and again. They describe it as a transformative experience and being able to be a part of this. And I don't want to put words in anyone's mouth, but that's just what we've been told at various points from many different people as far as how this worked. And that we're at a turning point, and that there's no going back to the way things were 5 years ago, if you think back to where we were before the CoIIN. And I think I can speak for many involved, and Kara spoke to this in saying that it feels deeply frustrating for people to see such confluence and possibility of true progress happening, only to feel like it will now be cut short and recede again without larger systems change. One of the key areas where progress has been made is around figuring out what it takes to really and truly do family partnership and what that needs to look like. So this will be touched upon in each panel today, but it's also a through line in all of the sessions today in the workshops and throughout the rest of the convening. And let me keep going here. In my attempt to be paperless, I need to scroll down. We are clearly focused on implementation in this QI project for the CoIIN. But while we are here celebrating the team's hard work, we'd be remiss if we did not lean in. And the point here is to lean in, to use that hard work to take honest stock with courage and candor collectively of progress that we made, progress we did not, and what have been the roadblocks. So that's part of what we want to be able to have happen and have you be able to talk through here and with the rest of the day and consider into tomorrow. And part of what that allows us to do for each of us, it's not just for families and for children with medical complexity. It's really for each of us because that's what we're all striving for and what brings the true joy because it allows us all to bring our full humanity to the work that we're doing. And that's really when you see that it's going to make the impact that we need it to make. So without further ado, for this session, we have 2 panels, 5 state teams each, grouped by the HRSA objectives of the CoIIN, one in the areas of shared plan of care as it supports the medical home. Those are 2 of the objectives. And then a second on unmet need. We don't have a lot of time. So we asked them to do a 3-minute opening, sharing one key learning. If you can only share one thing, what would it be? And then we've asked each of you to review the State Team 101 packets that's in the briefing book. And we also have a nice little spotlight graphic that Karina created at a past learning session for the teams. So you can peruse those as we're talking. And please then you're able to ask your pressing questions of the panel. And that does not stop here. Certainly they have their little ribbons for anyone that's in person, and then you can certainly engage on chat because there are state team members on the chat as well and pose questions there that we can bring to them. We'll have 15 minutes for each panel. And remember, this is an overview, and then the workshops, you'll get to dive deeper in engaging with the state teams to really cull from their experiences and bring those to bear today for how we move forward. So let's get started. So I'm just going to start on this side because this is where I am. So
Bethlen, sorry to interrupt. I just wanted to let the panelists know that we have Libby back here who's going to be giving you a 1 minute and time's up wave. So I've instructed her to do a little dance when it's your time, when your time is up, and just enjoy it, okay?
So Sarah, are you game to go first? I knew it. All right, Sarah Perkins is going to go first. Thanks,
Sure,
Sarah.
why not? I'll go first. So our team, as we were talking about this, we've realized the value add of having families involved in every level of creating a shared plan of care. And I don't just mean just the family that the shared plan of care is for or the patient, but even up to now, I'm sitting on chart review sessions and sitting there and going, I don't think this kid's ready for surgery because the plan isn't there. I also have the benefit of having gone through surgery and either having a shared plan of care or not having one. So I can kind of sit there and go, not so much. That doesn't work. This is why this didn't work. And now we also have a parent on our team, so she and I can kind of play off each other. So there's just value add everywhere of include the people that it's for, not just the bottom level, the top levels as well. And include patients, not just parents. Sorry, don't mean to throw parents under the bus, but include the kids in there.
Thank you, Sarah. Jill, would you like to turn on your microphone and then you'll be able to? Wonderful. Thank you.
Yes, ma'am. So I think thinking through the last 5 years for Washington State, it's the infusion of the partnership from the very beginning between the F2F and the project lead, in how our work was designed, in the components of what the work was, and how to create and then look at a model of support, especially for these new families whose kiddos are coming out of the NICU. This is a brand new journey for them. How to integrate and infuse the peer family leadership support for these families with clinical support to extend their capacity for resiliency, to extend their capacity for learning. But it then kind of morphed in so how do we take this idea, this concept, and look at the other work in our state, the other things that are happening in our state with complex families? What are those pieces and those components that can be brought over that that allow that collaborative work between the providers, the systems work, and the family-led organizations and the families themselves to work on connecting those systems for those families and for creating a way for families to have that ingrained participation in the care of their children. So
Thank you, Jill. Rahel?
Yeah, thank you. And so I sit here for Team Texas. And Sherry's here, my partner in crime, and a whole bunch of other team members virtually. The one lesson in relation to this shared plan of care that I just want to speak to right now is the experience that in our setup, the locus of change, primary change, was in the clinic, and so there is a whole lot of work around how do we engage families in creating the plan of care. But how does this plan of care get presented? How does it become accessible to families? How does it stay current? Um, how does it become useful to families who have difficulties with technology and language? But the reality is, and we did a whole lot of progress there in this pilot and a lot of work that we're proud of. The challenge we face that is that this work has to go in tandem with policies that support it. There isn't anybody who pays for putting a really up-to-date shared plan of care for families. There's no payment for it. But there's a whole host of other process measures and oversight paperwork that are in place that don't take into consideration this project. So it feels like they're not going in tandem. But the one thing I take comfort in is through the CoIIN, through the work of the CoIIN, we had made this perception, this assessment of things need to go in tandem, this reality. We brought this to the awareness of all the policymakers who can pay for our work. And we have, we're realistic enough to know that this is going to take a little longer than the kind of work that we have control over. So it is to say that a shared plan of care requires an integrated team. And for teams to work in an integrated manner, they have to sort of be rewarded for working in an integrated manner. And that policy change has to follow for this to be sustainable.
What you just said reminds me of the saying that the system is working exactly as it was designed.
Right. Yeah. And so, yes. And so this is system change that needs to follow and support the work that matters.
Thank you. Kristen.
I get to represent Team Indiana, and I'm so excited that we have an amazing team that is passionate about their children and families. And so one thing that I will say from Indiana is that special care was taken to this special plan of care to really integrate families and to think about all the different things. At the beginning, it was a huge project. It was a lot of paperwork and things like that. And through just a process of whittling down, we really got to what is important to the families, what is important to different entities, and just going from there and thinking, what could this shared care plan look for the education? What do physicians need to see and different things like that? And so it was really amazing to just see that progress happen. Not just, this is what it's going to be, but really to just process that and come up with something and then work with the families to make sure that it's something that works for them and to know that they have ownership of it. And so yes, it's just been an honor to see that. And then also from a state league perspective, to see the value add um, to just the state as a whole. And then, Medicaid in Indiana has decided to expand this. And so that is an amazing opportunity that not only the people that are passionate on this project, but also Medicaid sees the value of this as well.
And we're not just talking expanding, it's going statewide,
Yes.
it's going, including adult clinics.
Yes.
We're talking big.
Amazing.
Thank you. Sandra?
I'm Sandra Gilbert, and I'm with the Kentucky team, and I'm glad to come up here and present to you about what we've learned in our project. In the beginning, we started out with other people that were with our team, and that whole team has switched gears. We have all new team members. I'm the only one that's left from the original team, and so we shifted from wanting to do like 3 different type clinics to just doing the VCTC and the NIC unit with Dr. Goldstein. And through that whole process, being a family member and having children with complex needs, each group has showed me the importance that we do play in that part. And as we work with our shared plan of care, we continue to make changes to that and have realized that shared plan of care needs to have the information in it, that when they transition out to adult primary care, that they will have a summary of information and they could read it and really get to know who that person is. We've done tremendous strides with our VCTC and our telehealth clinics since we started. We've done a lending library for families because we have 120 counties in our state, that we would give them computers and give them access to use the computer so that they could get the healthcare that they needed during the pandemic as well. And even afterwards, we're still lending those computers and laptops or iPads to families. And just working with the different set of people that I've worked with over the 5 years, they have all been very accepting of a family member being involved in the process through the whole project. And I want to commend them for that. And they're going to continue to do that. And someday I'm going to retire and they're going to have to bring in somebody else. So we're just grateful to have been able to really look at the shared plan of care and focus on that area of making changes to the plan. So
I think that that's a good point. We hope that it's not contingent on any one person, right? That we want it to be able to be more than any one person. And could you say what VCTC is for everybody?
that's virtual care team clinics where we would bring in either primary care or therapists or the schools with the family, and we would all do a Zoom meeting together to make sure that the child is getting the services that they need.
Thank you. So we are going to take do a little just discussion. Let you all, both here in the room and virtually, be able to ask or bring up whatever you'd like to for teams to just to be able to talk to them and just call from them anything that you'd like to know. I'd love to get a time check so I can know I'm totally
We're
discombobulated.
giving you your full 15 minutes, so you'll be done at 11:35, and Libby's going to keep doing time check for you.
All right, thank you. So we're going to go back and forth. We'll start with in the room, and then if folks who are joining us virtually could raise your hand, and we'll chat how to do that. But there's you go to the reactions, and in there you can raise your hand on the reactions icon. So anyone in the room want to? I'm sorry, Libby's pointing at something. Oh, thank you. I thought we're going to get this down and then we'll be good. Chris, please go.
Thanks, Bethany. I'm really intrigued by Team Indiana's success at getting the shared plan of care basically bought into, and even noticed and then bought into statewide. And I was interested in sort of what was the value proposition that you made to get that done.
I think that honestly, sorry. I think there's a lot of things, but I honestly think it's the persistence of the passion of everyone on the project and the belief that what we were doing made a difference. And so just keeping that focus on this project is important and making that known. And then also just making sure to highlight that work at all times. And some luck.
Thanks.
But mostly just the passion and just the persistence.
Yeah, I think that behind that was a lot of meetings and conversations
Yes.
on a regular basis.
Yes, and that's what I was saying, the persistence of just making sure that we were always at the table, always just pushing that initiative. Dr. Chigarelli is an amazing person if anyone knows her. And so when I say persistence, I mean Dr. Chigarelli.
She is
Could you show
chatting.
her chat? Thank
Yeah,
you.
maybe we
You
can
gotta have
share
a
that
session
chat. Yep. So you said shared plan of
Right.
care was accepted by
together.
an
Family and critical team satisfaction. Wow,
Mm-hmm.
that's an easy sell.
There's some very, very compelling data to show that came through the CoIIN, and also very intentional measures for yourselves. So we'll go to virtual.
Yeah, there's a question in the chat. It's from Jeff Schiff, who's actually in the room. He says, can you talk about telehealth? What worked? What did not work? What did you measure? How did you measure?
Is there anyone that would like to speak to that first? Maybe we'll start with Team Kentucky since you were particularly focused on that. And then if anyone else has anything to say about that.
So we had piloted telehealth prior to the pandemic. So in a couple of our offices, of course, we have 11 offices throughout the state of Kentucky. So we had already started to pilot that. And then when we started the VCTC, then the COVID happened. And then we were lucky enough to have worked with Medicaid on that as well. And we were able to bill for those services through Medicaid because at one point, our new medical director used to be on our state team. And then she switched positions. So, but we had done that before she switched those positions. And we had Dr. Lou with us in the very beginning. And at that time, he was the Medicaid director. And so as soon as the pandemic happened, we felt like we really needed to reach out and continue to reach out to those families. So we really increased from around 700 visits a year to over 4,000 visits for that first couple of years of the COVID. So it's and then the help of us having the lending library to give those families in those rural communities that did not have access to the internet or computers, we were able to provide that to them. So I think that was huge, and we were able to provide the care that they needed during that time.
I just have a brief comment back here. If the panelists could get nice and close to their microphones when you're speaking, that would help our virtual participants. Thank you. We have another question that's in the chat. Patience White asks, how was a transition plan worked into the shared plan of care model in the CoIIN?
I don't know who might want to field that and considering it. I don't know that anyone here was the focus of their project and where they were looking at the continuum of care across the life course and within the from children to adults. But I don't know if there's anything that you'd want to say that you realized in the course of doing the project around transition.
Yeah, I'll speak a little to what we tried to make sure that transition is addressed. Our shared plan of care is has different categories, different problem lists, let's say. And for children who are 13, 14 and older, there is a section on transition that is informed by the transition checklist. And we are now including in our assessment of how this visit, we have this visit where these care plans are updated twice a year. And when we are evaluating this visit for those children who are appropriate, who are old enough, we ask the parents also if this was discussed and if the plan actually reflected their priorities. So we're beginning to try and include that as part of the standard of care for their biannual visits for those children who are of age. So that's how we're trying to address it.
Thank you. And Sandra mentioned that. And also just to know in the next panel, Team Oregon did indeed focus on transitions. So you'll be able to hear from them in the next panel. Go ahead, Sandra.
So we didn't really focus on transition, but that's something that we've always done within our clinic setting. And we start at a very young age with our kids just to make sure that they're reaching their milestones that they need. And then our transition continues until they age out of our program at 21. So when they leave us, we want to make sure that they have a plan that shows everything that was provided to them through our specialty clinics so that they can take that on to their new adult doctor and he can look at that and he won't have to be searching around for all these medical records and neither will the parents have to be searching around for all of these medical records. So we thank you very much. So, that's something that we've always focused on. And I think it's very important that we do focus on that because the parents don't know a lot about transition. And when you start working with the family to family, when I work with them, we talk about like everything that's going to happen within their lifetime and what they're going to need to do. And with that shared plan of care, and they give that to the physician, I believe the adult physician is really going to see who that person is. And that's what we're working on to get that to that point. And, it doesn't matter that it's going to be 20 or 25 pages. It's going to be electronic or you can have a paper copy. But it's the important piece is that when that child leaves us, we want to make sure that adult doctor knows exactly what has been going on with that child and what his goals are and what he's going to need in the future.
Thank you. So I have to apologize because I'm not going to be able to do things in order. But I want to give us a chance to we have a few more questions here. So I want to make sure I see them in the room. I'm not sure if there are any also virtually. So I'd like to, we're okay with moving on to the next question. Does that sound all right to folks?
Bethlen, I'm keeping tabs on the room, and I think Jennifer Lale was the next in-person question. She's been patiently waiting.
Can everybody just say for a moment, I just have to say I love Livy. Okay, so Jennifer Lale, you are next in the queue. Thank you.
Thank you, and congratulations to all of you on astounding work. I want to ask
Jennifer, can you go a little closer to your mic?
Yeah, thanks for all the astounding work. And I'd like to ask Texas, in reviewing your report, you have an electronic care plan in English and Spanish that is on smartphone and integrated with EMR. It sounds like heaven. Do you have it packaged in a way it can be shared?
Yeah, absolutely. It is, we have demoed it to other state teams who had wanted to see how we're doing it. And it was an iterative process where it took multiple versions. We were initially asking providers to document the care plan in that separate platform. The integration with the EMR happened over just the last year, and what made it really easy. So it is. We've used the asthma plan of care template of having green, yellow, and red for the different situations that families might face. And if they're taking care of, this is the daily care is green and the PRN care. So what do you do in the event of an illness, whether it is the event of increased seizures or acute respiratory illness? There are the guidelines written there and crisis plan. And that goes for a whole host of issues, whether it's sleep or behavioral crisis or medical issues. So it has been very very well adopted by families who have been able to come on the app. And Sherry actually does that onboarding of families onto the app. In addition to that, they put in their symptoms in there. The app has enabled a two-way communication. It's not just us putting information out. So it's been work in progress, and for the last 5 years now. It's a pretty routine thing that's done after a whole child visit, which the parents have renamed the well child visit. The well child care is now the whole child care. And we do it twice a year because we feel like 1 year is too long for all of these moving parts. And again, we don't have a system that pays for twice a year whole child visits. Hopefully these models are going to lead to demonstrating better outcomes and better satisfaction, and hopefully we will someday get a payment system that matches it. I don't know if I've answered your question, but I'm happy to share offline also, and show you and then demo the software that that we use.
Can you say which electronic record you're working with?
Say again?
Can you say which electronic record you're working with?
So the EMR is Athena, although you can put text macros in Epic or any other system and be able to do the same thing.
Rahel, I wonder if there's screenshots of a template or something that we might be able to upload to the Bragg folder or something that we could share with
Yeah,
people.
absolutely.
Yeah.
I think
That'd be great.
yeah, we have things we can upload.
That would be great.
Yeah.
And I would like to give one more question and then we're going to be done. So I'm sorry for folks that we didn't get to in the room, but if you wanted to, you should write down, or we can make sure we get to chat your question, or you can grab people after as well. Do we have anything virtually?
No, none in the chat, and no one's hand is raised, so we should just take the folks in the room who have raised their tent cards.
Yep. I wanted to make sure that the folks got a chance just while we pause for a second, and then we can go into the room.
I've
Yep.
been trying to keep track of who goes first. So over here in the second to last row, I don't know your name. I'm sorry, in the black shirt.
I believe it's Allison.
Yep. Hi, this question is for Jill. Hi, Jill. I was wondering if you could share a little bit about the peer navigators in your state program.
Yeah. So we in our program we had a combined navigation system. So the hospital itself, Seattle Children's, had community navigators, and then we worked with them hand in hand and had a family peer navigator who had a child who experienced with NICU. And they worked together to really look at how to transition that family from hospital to home. And then with COVID on top of it, how to virtually support that family over a year through different methods of connection. And go back to the hospital when families had questions. So there was that access to talk with the hospital and ask questions with their care coordination and around their care plan. And we utilized the roadmap to do that.
And we can make sure that gets uploaded so people can directly see it. It's in the Bragg folder. In the Bragg folder, people. And just to note that Jill is with a family led with the F2F for their state. So it's really neat to see how they've blazed some trails in building those partnerships and continue to find ways to do that in the state with healthcare systems. We need to move on. So I am going to say thank you, and we'll do a round for this crew here. And for anyone that has additional questions, you can chat them or write them down, and we'll make sure that we can get you answers. You can grab anyone you want. And in the meantime, who next do we need to have come up, Ben? And I can put those out for you if you want while we get folks up and you can start chatting.
Great. I'm going to go return this mic over here first.
I'm going to make one request for people in the room. If you put your tent card up, just make sure it's not right in front of your body so I can see it. Thank you.
For the panelists and people asking questions in the room, please get as close to your mic as possible. I think I made some obscene gestures to the first panel from the back of the room, and I think we've had enough of that. All right, so we have 4 more of our state team members coming up. We have Shreya, Ellen, we have Rhonda, we have Becky, and then we also have a virtual panelist, Kathy, who we would like to spotlight for this panel too. So please make your way up here and sit where your name tag is. Yeah, I think that chair is for me. Can I get my water bottle? Thank you. All right, so thank you to Bethlyn and the panelists from the Shared Plan of Care and Medical Home panel. My name is Ben Plant. I am the research assistant at the network level on the CMC CoIIN. In a moment, I'm going to have our next panelists introduce themselves, but I figured I would introduce the panel first. So the next objective focus for this panel is unmet needs. Specifically, as a part of our 4-year HRSA grant, we had a goal to increase by 25% the number of cohort enrolled families reporting previous unmet needs are now being met. Unmet needs were a focus area for our state projects, as we will hear about in a moment, and also our mixed methods evaluation, as unmet needs greatly affect the well-being of families and also child quality of life. Speaking from my perspective on our network level evaluation of the project, we learned a lot about unmet needs, and we also learned a lot about how to measure for them. We learned that unmet needs are not just medical. Families have respite needs, they have nutritional needs, they have community support needs, just to name a few. We also learned that not all families fully understand what their unmet needs are outright, especially when asked via a survey question. When probed further via direct conversations with families, they often uncover needs they might have not known they've had. We had this experience in focus groups and also with speaking with the family leaders on the project. We were getting more than 80% of families who were completing our state team surveys saying that they had no unmet needs being met. But then when we talked to them in the focus groups, we heard all sorts of unmet needs being shared. So that's only the start of what we learned on the network level evaluation around unmet needs. But we also have gathered representatives from our state teams here who worked on the ground and talked to family members about their unmet needs directly. So now it's your time to share. This is the time where you'll share that one learning you have if you couldn't share anything else. We'll go down the line. If you could start by introducing yourself, your role, and your state team, and speak for 3 minutes. And then again, we have Libby in the back who will do her little dance at 0 minutes. Great. So Becky, are you free to start? Yeah.
Absolutely. So I'm Becky Burns. I'm the statewide coordinator for the Children Needs with Special Healthcare Needs program in Wisconsin. So my role on the team was the Title V representative. What we learned right off the bat with unmet needs was that the shared plan of care was identifying all sorts of unmet needs, but our CMC CoIIN teams weren't sure how to meet those needs. And so we got involved by pulling more and more community representatives in, family members in, and wanted to see what we could do about making sure that children in the CMC programs were also in the what we call children long-term support waivers, the Medicaid waivers for children.
And when we started, only 32% of our kids were in those waivers, which made no sense to us because we figured at least 99% would qualify. And so we had to do some research to find out what were the barriers, why were these kids not getting in. And there were a lot of myths out there about what case managers or support coordinators were telling them at time of application about whether or not they really needed the waiver, or whether or not they had a need that would really be supported by the waiver, all sorts of stories. And so we needed to get past those stories. So we created packets that every family received when they came to the clinics that had a letter from one of our parents on our team explaining what, in plain language, what the waiver is and why, yes, you want to be on it. And in 2 years, we were able to double the numbers of children from 38% to 62% of our children were on the waivers. And when you figure it's about $1,000 a month, that's $3 million a year that were going out now to these families that weren't going to them before. So they were meeting lots of unmet needs that they were previously not doing. Now, we haven't checked the numbers since then. Hopefully, we're still moving in the right direction. We have the pleasure of living in a state with no wait list for the waivers. So there's absolutely no excuse for these families not to be receiving that service.
Hi there, I'm Rhonda from Minnesota. I'm the clinical site lead. So, but I'm a researcher. I'm not a clinician. So just to give you a little bit of background about our Minnesota team. Thank you, Becky. Our complex program started literally a year before we joined the CoIIN, with one provider, one nurse. So we were newbies and had a lot of unmet needs from a programmatic standpoint. But as we continued with our work in the CoIIN, what became evident is we didn't have a good process in place as new families joined the clinic, and it grew exponentially. We now have over 700 families enrolled in the clinic. Identifying their level of care coordination need, not care need, care coordination need, and then being able to kind of equitably distribute new families to the appropriate care manager so that one care manager didn't have all the super high need families. And we also learned that our communication between providers and care managers, because providers were not in the clinic setting, they were in a different building, didn't always happen. And communication about family needs from a care coordination standpoint didn't always happen. So working with our CoIIN team, and I was fortunate to have a nursing student, we developed a care coordination needs assessment. And honestly, we took, I think it was Stacy Cook did a talk about this. I can't remember if it was for the CoIIN, the Care Coordination Academy, about having something that's really easy, Johnny on the spot, being able to implement. And so with one of our providers and two of our newer care managers, they met once a week, basically a huddle. It only took 15 to 30 minutes and talked about all the new patients that this provider had seen. And he was amazed at the number of things that, oh, I forgot to document or communicate this to the care managers, that the care managers were then able to follow up on. And again, it was all about good communication, but it really helped our program identify the unmet needs of communication so that we were better able to address the unmet needs of our families.
Thank you, Rhonda. I really appreciate you highlighting communication and equity. Those are two big areas of focus around unmet need.
Hi, everyone. I'm Ellen Cruz. I use the pronouns she, her, hers, and I'm a part of the Team Colorado. I'm the project manager. Unfortunately, David Fox, our PI, was not able to join, so you have me. And when our team thinks about unmet need, a lot of it comes back to listening to families. When we started out the project, it was mainly just listening to families to determine what our project was even going to be. Where were those unmet needs happening in our system, and how can we address them? A lot of it comes back to really taking the time to have that genuine participation and not have just lip service. And then also thinking about in the clinical setting, We worked with families. We came up with a Just Ask campaign where we had providers just ask them what's going on, where are their unmet needs happening, and helping them to navigate that. And that goes beyond just our normal screeners. We have a psychosocial screener that helps to kind of narrow that down a bit. But having that conversation in the clinic is really important. I say also that we have family navigators within our clinic. They're really beneficial. It's automatic referral to them when they have a psychosocial screener, but that conversation in the clinic can also lead to a referral to them. And that can help them to navigate inside and outside our clinic, including Medicaid waivers, any other type of social determined health need that's happening, and that we also have them a part of our affinity group. So we have a family group that we gather and continue to get information from them around what are their unmet needs, what are happening, because we don't know what we don't know, but we've also found that they don't know what they don't know. They don't always know what services we have within our system. It's a very large system. It's hard to navigate, and it's hard to know what everyone's roles are. So when we have that family navigator a part of our affinity group, we're able to really have more of an open conversation and be able to come up with quick solutions. But for those long-term solutions, thinking about how we can have the families involved with addressing that unmet need in the clinic, but being a part of that solution all the way through. So they're not just happening at the ground level, but at the systems level with us.
Thank you.
Hi, my name is Shreya Roy, and I served as the project coordinator for the Oregon CoIIN team since 2019. And last year, I transitioned into the role of the evaluator. So today, the key learning around unmet need for transition for young adults with medical complexity that I wanted to share with you is the importance of starting transition preparation early and often. This is something that we heard from our families who we interviewed as part of our environmental scan, those who had recently transitioned to adult care. And they really emphasized the need for receiving information about transition multiple times over the course of multiple healthcare visits, because there are many immediate needs that they have to take care of. And so repeating this information over a period of time helps prioritize this. Uh, and it can also help providers and family members process some of the emotional aspects of transition. And ultimately, it can facilitate transfer when the time is right. So this brings me to my second point. When transition is talked about, usually the transfer of care to the adult provider is what is there's a lot of emphasis around. However, for that to be successful, transition preparation has to happen. It has to happen early. It has to start early, and it needs a lot of attention and focus. And so transition is not just limited to transfer of care, but it's a three-stage process. It's preparation, it's transfer, and it's integration into adult care. And each stage needs unique attention. Of course, for all of this to happen, payment is absolutely critical. For this to be sustainable, for providers to be able to do this work, for providers to be able to do what is right for their patients, payment is absolutely essential for this to become a standard of care delivery, for this to be routinized into the regular care that patients receive. That's all I wanted to say. Thank you.
Thank you, Shreya. So now we have Kathy, who is virtual. Kathy, your time.
Okay, can you all hear me?
Yes.
So I am Kathy Caldwell. I'm Alabama's Children and Youth with Special Healthcare Needs Director, actually in the Alabama Department of Rehabilitation Services. So our CoIIN project primarily focused on a partnership between our Children and Youth with Special Healthcare Needs program that I'll call CRS and the University of South Alabama Pediatric Complex Care Clinic that I'll refer to as USA. So we were fully aware of many unmet needs across the state, particularly in the South Alabama area. And all of those unmet needs, such as, too few home health nursing services, respite care, especially equipment, transportation, et cetera, all of that held true. But we identified other areas of need, and certainly with COVID, many that we identified and were aware of got worse. But we realized that care coordination across multiple settings was vitally important. We placed a care coordinator, a CRS care coordinator, actually in the USA clinic. This was huge in coordination of care across these two systems. It actually allowed both USA and CRS to better deliver services. Our eyes were really opened related to the number of children with medical complexity compared to the amount of resources available. That brought about a lot of frustration in trying to match, the needed resources with those available. And like I already said, that situation certainly was burdened even further by COVID. We heard loud and clear from families that they wanted the medical staff to know their child. And we learned this through conversations around the design of our plan of care. They wanted the clinical staff to know what their children liked, what their goals were, just really form a personal relationship with them. We, due to the fact that there is not currently a family advisory council in place in the hospital, there was limited ability for families to give their input. So certainly we tried to positively impact that. One thing that we found a little bit surprising at our very first focus group was there was, from our perspective, an unusually high number of children who were either being homeschooled or they were on a home-based program for their CMC child. And we have not yet been able to dig real deep to find out what's driving that, but our sort of fear and suspicion might be that the school system encourages that setup, because maybe not adequate resources to address that. So moving forward, we will continue to focus on advocacy for CMC and stronger partnerships with all service providers to help build a stronger system of services for this very vulnerable population and their family. And we're working to spread what we call the CoIIN model. Just great value came out of that partnership. So we are in discussions with other entities around placing a care coordinator to solely be the liaison between the multiple partners. So I'll be happy to answer any questions anyone has.
Thank you so much, Kathy, and thank you to all the panelists you really kept it to 3 minutes, and I appreciate that. I would also like to thank Ellen for bringing up the family partnership piece. We were intentional about not having a just family partnership panel or a just family partnership workshop, because we really feel like we don't want that to be separate. We want it to be integrated into the panels and the workshops that we're hosting throughout the day. And you're already making a point of that, so thank you so much. All right, so now it's time for questions. I think we're going until 12:10, so we do have the full 15 minutes. I think we started in person last time. Do we have any virtual questions?
We do not at the moment.
Okay, do we have any in person? I see one. Yep. I think that's Eileen. Yep.
Hi, everyone. It's Eileen Forlenza, family leader from Colorado. I have a question about connecting the unmet need to the shared plan of care. So what strikes me as a parent of a child who needs a lot of care, that the EMR, that's what that was supposed to be, right? The whole EMR thing was all about so that clinically and within a system, the care providers see what the shared needs are. So then I was thinking, well, then is the shared plan of care about the care part, which for the parents, that's what we do, right? We're doing all the care part. which is not clinically based. So then I was thinking about what Steve Fitton said this morning and saying, how do we capture what's happening by families that is not being paid? So I'm curious about if this team or members of the other panel can connect on the shared plan of care. I'm going to keep focusing on care as a family leader. Is there a way, or have there been discussions about how are we capturing what is being, what the care needs are? Does that fall under the unmet needs part? How do we look at the care needs that are outside of a clinical setting? And then how are we equalizing that as colleagues, as part of the workforce that we know is critical for this population? Is there a way at this level of this wonderful advisory, this great team that we're working on this week, how do we begin to level that playing field so that the shared plan of care is truly focusing on the care piece and not the clinical intervention?
Great, Becky.
I was hoping I could bring up our gold cards, so thanks. That just slid that right in nicely. So the other project that Wisconsin did was create these gold cards. It's now an online application that families can go through to help figure out what their goals are for their kiddos. I think that's the key to moving the shared plan of care from a clinical document to a family-focused, family-centered document, so that the goals that they're talking to their clinicians about are really their child's goals, not their child's medical goals or their child, So they take this, they go through the application, they come up with a list of their goals for that child, and they take it everywhere. They're going to take it to do the shared plan of care. The IEP is going to focus on the same goals. And if they're in one of the waivers, that service plan is going to be developed around those same goals. So now we're finally gotten the focus back on the child or the family and how those systems can support that child's goals. I'll tell you the greatest part of the goal cards, which we have in physical form, we have it online for those televisits, and now we've got the app, is the number of times a family does it with a child and says, oh, dang, I never knew you wanted that. So that's just been cool. Total just unexpected outcome is that the children's voices are starting to be heard. We also have families of older children who use the cards. Some of them say, well, not super helpful. It would have been helpful years ago. But we've also heard families say, man, that made me think of goals that I never have thought. We've just gotten stuck on communication for 12 years. And I never thought about social stuff for this kiddo. So it's, again, not intentional in our plan and our design, but it's turned out to be really beneficial for families. And so that's where we're trying to get the integration of the child's goals, which should address unmet needs, more universally met.
Thank you. And I believe that the goal cards are in your brag folder, correct? Yes, I put them there with your assistance, the Team Wisconsin brag folder. Rhonda?
Well, I'm going to go out on a limb here and talk a little bit about what we're hoping to do. Like our next iteration of work is, because we don't have a EMR that supports a shared plan of care, we've been looking at other technologies, and we're trying to sell to our leadership really a family-driven plan of care and care mapping tool where, the problem with the EMR is families can't provide input into the document, and it doesn't work. It does not work. So there's tools out there, and one that I can talk really about is the one that was developed by the group from Boston Children's and Duke University as part of our first grand challenge, where the parents basically have control over the plan of care, and they can share it and allow others to update that plan of care. Clinicians can update it, but other people can't change it. So there's guardrails in place that the information that's in there is accurate, it's safe, but it allows families, young adults as they get older, to truly have a say in identifying their unmet needs and how they can get them met.
Thank you, Rhonda. Anyone else? Kathy?
So we've not worked out all the kinks, and I know sort of theoretically we'd love for all systems to talk to each other, and unfortunately in our state most of them don't. So our care coordinator that I talked about, she really was the only one who had access to both the USA system and the CRS system. So the interoperability certainly is not ideal. But yes, the shared plan of care, right now it's in paper form. We're working towards it being electronic. But yeah, it was really more for at a snapshot. The family could take it to their next appointment and, in what 1 or 2 pages see both clinical information and, as I said, the most popular piece is information about the child, what the family wants the clinician to know about the child.
Thank you so much, Kathy. I think we can move on to our next question. Do we have any virtual? No? Oh, okay, now we do.
Ivy, please go ahead.
Okay, I'm going to brave this because our wonderful conference leaders have been asking us in the chat to ask our questions verbally and come on camera. So I'm interested in how you handle needs that you can't possibly meet, and maybe some examples of some of them. Just wondering what happens when you identify something and there's truly a brick wall you don't have the levers for. Thanks.
Thank you. That's a great question. Who wants to take that big question? Okay, I think we've got Ellen.
I'll try and tackle it. I think one of the first things that comes to mind for me is when we're thinking about whole family and unmet
Oh,
needs.
could you speak a little louder?
I'll
Thank
make it
you.
a little closer.
Yeah.
When I think about whole family and unmet needs, one of the things that's, an epidemic happening in the US right now is mental health. I think that when we open up the jar of worms and we ask families what are they having issues with, what we can help with, sometimes it's around their own mental health. And right now, just with the way that our mental health system is set up, it's hard to get people in to get access to those things. So I think one of the things that we try and think through of how can we overcome some of those barriers is, can we connect with them other groups? Can we get them the respite care they need to kind of alleviate those additional stressors? So those are the things that I think about when I think about things that are identified that we don't necessarily have set up in our system to really address.
So Ben,
Yep.
can I add just a little bit?
Yes, you can.
So certainly there are resources that there are just too few providers, or certainly with COVID, the supply issues. So we try to get creative, and I'm sure there are still needs that we've not been able to address. But I did talk to a staff member, even in preparing this information, about formula, for example. We have staff spending a lot of time and resources in trying to match families who need specialty formula right now and can't get it. And sometimes the solution's not ideal, but at least they're working furiously trying to get at least a suitable solution. But there are some families that the child actually has to be admitted to the hospital in order to get the formula that's needed. So sometimes by no means is it the most ideal situation, but we are out there trying, to match the resources with the need as best as possible.
Great. Thanks, Kathy, for bringing that to a situation that's happening right now that we're all facing. Okay, I think we have about 5 minutes left, so maybe we can transition to a in-person question. Libby, who was next?
Rishi is next, and if we happen to have time, Renee is after him. But
Okay, great, Rishi.
Great, thank you so much. Really great panel. Thank you for sharing all of your experiences. I think that this is partly a comment and a question. I think that the vast amount of unmet need, really illustrates how difficult it is to create payment mechanisms that will save money on total costs of care. And I think that's just something that we have to grapple with as a field, because that's something that we have used as a hook to get people interested in this population. And I think this panel's comments show how difficult that is. But my question is specifically for Wisconsin, because you actually quantified that a little bit and talked about how, there's $3 million more going out the door. And I know that Wisconsin has done other things in the past that have, potentially saved money in other, with complex care coordination and everything. And I was curious, did you get any pushback, or was there any challenges you had about, doing activities that clearly put more people, more folks, to get these services that have a cost associated with them?
I think you're all set now.
Yeah, got it. Yeah, thanks for the question. So what was handy was, at the same time as the CoIIN was developing, we got Medicaid to pay for the complex care coordination for CMC kids. Because that happened, somebody in Medicaid had to be involved in this, and that person also then was very closely connected to the waivers. So we were building those intersections so that if there was going to be any pushback, we'd know about it before we went way forward with it. So it's about bringing everybody to that same table so that those conversations could be had. There was no way anybody was going to argue if these children should be on the waiver. So that was the easy one. But it was a matter of kind of cleaning up that system to make sure that they weren't, the end users out in the counties weren't inadvertently being too tight of a gatekeeper to those funding. So those funds are there for those children. And so we wanted to make sure there weren't unintentional roadblocks in the way. So no, we didn't get pushback.
Great. I think do you have a quick question, Renee? Great. Then I think we can fit Renee in.
Be quick. I just want to say congratulations. This is an innovative, inspiring, and humbling. My comment and question is, I think it was Oregon that talked about transition, and one just plug for Got Transition. I think Meg or Bethlyn mentioned it earlier, but there was just recently a big coding sheet that came out. I think it was as recently as this week, so we should make sure everyone has that. But you had mentioned payment. It made me think of that coding sheet. And I just wondered if you could comment on any success that you had, or with getting the transition codes paid for. Thanks.
So
Oh,
Shreya is actually going to defer to me. This is Allison Martin in the middle of the audience, and I'm Oregon's project director. So we've been making incremental progress in trying to work with our state partners, and Got Transition has been an absolute key partner in talking to our health policy division and Medicaid folks to try to make some forward movement. I think we're running close on time, so I'm happy to say more about this offline. Yep.
all right. Thank you so much. That's all the time we have. We're already running a little bit into lunch. So we're going to transition to that now.